Well, thank you all for joining us today. I'm Amy Godkin. I'm Executive Director of Ask Childhood Cancer Foundation. Like all of you, we're providing direct support services to children with cancer and their families. A couple of quick housekeeping items. Britt is helping me today with technology since I'm having challenges with my laptop. We are going to mute everybody during Bo's presentation. If you have questions, post them in the chat, and then he'll answer them all at the end. And then if we still have time, we'll just kind of open it up for a general chat. We are going to record this session in case folks would find helpful for us to post it and share it out online afterwards. So I hope that's okay. Over the last few months, I have found it extremely helpful to be able to get advice from our speaker today. Dr. Vaughan is an infectious disease physician with the U.S. Department of Veteran Affairs. He is on our board of directors, and he also happens to be the parent of a childhood cancer survivor. And so Britt and I have found ourselves asking him questions every few weeks about, you know, how do you think we can do this, and when do you think we can do this? And I had other EDs saying, what's your guy saying about this, and what's your guy saying about that? So that's why I invited him to speak to us today. So Bo, do you want to take it from here?
Yeah, sure. I just wanted to welcome everyone. Thank you for coming out. I know this is really trying times, trying to make sense of a world that is, you know, turned upside down. And I just want to make sure everybody knows that, you know, I'm a physician. I don't know your individual programs, you know, down to the granular details. So what I'm going to present today is by and large, how do you operate programs that kind of almost are like maybe camps or a school setting, because so many of these programs that we help out with children with cancer have that format. But I know that there are a lot of other programs that don't look like that. Like, for instance, if you go out to someone's house, and so we can talk about that at the end, but there's so much CDC guidance that I want you all to be aware of that can really help you reintegrate your programs in a kind of a staged fashion. But just to let you know that at the end is a perfect time to really get into the weeds with your unique programs. And I'll talk for about 30 minutes. And then after that, I'll field questions for another 30 minutes or so. And I'll make sure Amy can get you guys my email address. I'm happy to answer questions. As she said, my daughter was diagnosed with ALL in 2016. And she was under treatment for 2.5 years, and she's fortunately done well, and she's now, you know, about to go to her 8th birthday party Saturday, which is great. But it was definitely a really trying time. Ask is, you know, kind of our home cancer program that helps out families and services for families, and they were tremendous in helping us get on our feet, make sense of the conditions of this new normal that, you know, we still live in. And you guys are doing the same type of mission, so I want to be able to help you out. So without further ado, I do want to say just thank you for what you're doing. It's a population that needs as much attention as possible. So let's see if I can move the slide. These are my objectives for today. I think it's important to kind of have an overview of COVID-19 basics. What is this virus? What are the signs and symptoms of COVID-19, the disease? Obviously, the virus that causes it is SARS-CoV-2. You'll hear me jump back and forth about with those kind of that lexicon, but just know that that's the virus is SARS-CoV-2, COVID-19 is the disease, and then how is it transmitted? The third item is promoting activities to reduce the spread. How can you do that with your programs, and maintaining healthy environments? And I'll talk a little bit about epidemiology of COVID-19, because I think it's important when you're looking and hearing your governors, or our governor, because everyone on the call today is from Virginia. We will have a certain kind of phase 1, 2, 3 look, but if we do have to go back a phase or two, depending on the transmission in the communities and statewide, we might take different postures. So I think knowing a little bit of epidemiology, I'll put it in kind of non-epidemiologic terms so we can make sense of it and make predictions and be thoughtful in our decision making. So those are my 5 objectives for today. So here are the basics. So I'll just say this all began with a lot of chatter about bats. What do bats have to do with COVID-19? Well, back in 2004, most of you remember the SARS outbreak that is by and large a very similar virus to that virus back then. It actually is derived from a coronavirus that is interchanged between many mammal species, but particularly this horseshoe bat. It's a hideous looking creature. But coronaviruses are widespread in so many different species. All the ones here: birds, rabbits, reptiles, dogs, cats, pigs, bats, camels, humans. And even in human populations, I'm an infectious disease doctor. I deal with coronaviruses all the time. We have 3 to 4 endemic ones that live here. But this one, what is so unique about SARS and MERS of 2012, which was kind of a Saudi Arabian, Middle Eastern outbreak, is that it was a zoonotic infection. All that means is it jumped de novo, or jumped from an animal species to humans, and no human who walked the face of the earth had immunity to it. So it was a new virus for humans, and thus disease typically can be more severe when you don't have any immunity to it. Where did this virus come from? This is the object of much study and consternation. Obviously, there's a outbreak in and around a wet market in Wuhan, China. Whether it originated there or not, that'll be further discussion. It's not really what we're here to talk about, but that was kind of the epicenter in and around the Chinese New Year, when 50 million people had left that city in China, which is about the size of London. It's a large city, and thereby causing a cascade of spread, which was it was a very unfortunate timing, let's just say, for the Chinese New Year to correspond or actually go alongside of an outbreak scenario. So that is the kind of very origins of it over the December 2019 month. So this is a respiratory virus, and I'm going to kind of post these. These are CDC kind of postings that you can post in your locations where you are, or in your clinics, or at your camps. Or I think this can speak very clearly to parents and some patients as well, that are very easy to understand. There's a treasure trove of these type postings. But it breaks down simple symptoms. So this is a respiratory virus. It's a virus that is spread from large droplets, typically. Droplets that typically only spread 6 feet in radius around an unmasked person. And the symptoms, if you do acquire this, fever, cough, and shortness of breath are the predominant ones. And symptoms typically arise about 2 to 14 days after exposure. Of course, when we unpackage this, there's a lot of variability that's important to consider. For children, actually, I was on a very large conference call for the National Association of Independent Schools 2 days ago, and I was on with the chief of pediatrics from Northwestern, and she said in her estimation that the majority of the cases that she sees in children, the incubation period is about 2 days. So you'll be inoculated, and then usually 2 days later, a child will start showing symptoms. Now, in our cancer patients and the children we care for, that is a completely unpredictable time frame. Usually immunocompromised kids who develop a respiratory disease or even a diarrheal illness can shed virus for long periods of time. They may not have any symptoms. They typically do just fine with respiratory viral illnesses. Now, there's some exceptions to that rule. The United Kingdom actually said that even immunocompromised kids had handled this coronavirus very well, and it was the adults that consistently showed more invasive disease. But this slide was from New England Journal of Medicine, where it shows that the usual time at which you show symptoms after inoculation is somewhere in the 3 to 5 day range, and those were adults in this study, but kids maybe even less. Immunocompromised kids, somewhat unpredictable, but I bet you it follows, again, this trend. I would also say that some things that you can do with regard to the slide that I've got, it's really important to educate your families that you're going to be supporting, and put these postings up in your areas if you haven't already done so, and develop kind of broadcasted announcements on reducing the spread of COVID-19. There's a whole bunch, as I said, of communications that can be borrowed from CDC websites, from multiple websites, but CDC is a great one, as I said. Let's move on to CDC's laundry list of symptoms. Again, under the auspices of this is the basics, CDC COVID-19 basics. CDC says there's about 11 major symptoms you need to consider. And fevers, chills, obviously being the predominant one, but cough and shortness of breath, fatigue, muscle, body aches, headaches. Now those last ones, fatigue, muscle aches, headaches, those are typically what I call under the umbrella term of flu-like symptoms, including fever. So new loss of taste and smell, sore throat, congestion, runny nose, nausea, vomiting, and diarrhea. We'll tell you that in the pediatric population, there seems to be quite a bit of GI illnesses with COVID-19, particularly early in the disease, which might take a little bit different form in adults. Emergency warning signs, trouble breathing, persistent pain in the chest, new confusion, inability to wake or stay awake, bluish lips or face. Those are all reasons that kids need to go to the emergency room or see their doctor immediately. Those are very concerning symptoms. The reason why I bring this up and want you to have fluency with these symptoms is it'll be important for not only your staff to know these symptoms, because it's not only kids, it's your staff that needs to know not only to identify these symptoms in yourself or the kids, but when to stay home. So here's some of the things that the CDC says. Actively encourage employees and students who are sick and who have recently had contact with a person with COVID-19 to stay at home. And those are the symptoms to watch out for. Develop policies that encourage sick employees and students to stay at home without fear of reprisal. So I know Ask, we had discussed a little bit about this. Some of the staff, we wanted to make sure that people could stay home if they were worried about, and they could telework in without fear of reprisal, losing job or anything like that. Develop policies in and around that. And ensure employees, students, and their families are aware of those policies too, as you consider starting camps or having events. Consider not having perfect attendance award. That's more for schools. I would say you're not doing that for most of your programs. But in really getting the word out about these symptoms for staff and students or children to stay at home when we do reintegrate. And who reintegrates, of course, there's kids that are on treatment, who are not on treatment, siblings. We'll talk a little bit more about that later, but getting the word out about what symptoms to look out for is important. I want to talk a little bit more about the infectivity of this virus. So in epidemiology, you may have heard of this term rho naught. Oh, it's this R0. It's how infectious is this compared to other virus. And it's typically considered to have a rho naught of 2, or this reproduction number of 2. So what does that mean? I've given you a little diagram of this. So patient 0 who comes in typically infects up to 2 people. And those 2 people, they're after that, infect 2 more people, and so on and so forth. Let's look at some other viruses that you were familiar with. So look at the very top in the number 2 position, influenza. It's more infectious than influenza, but not by much. It's similar to influenza in its infectivity. MERS, the other coronavirus, is actually spread less frequently. But when you look down at measles, there may be some people on the call that may have seen measles, may have had measles. Measles is the most infectious virus in the whole world. And typically the rho naught is around 13. So for one index case, there are 13 transmissions after that. So SARS is, COVID-19 is, or SARS-CoV-2 is far less infectious, but it's a respiratory virus. So I don't want to blow it off either. But I just want to see this in the pantheon of different viruses that are there. It lives in and around influenza, but slightly more infectious than influenza. So how does that have bearing on programs and bringing kids into a classroom or maybe programs that you want to consider starting in the months ahead? So what you have here is a mom bringing their child to school. how do you promote activities to reduce the spread? So I think something that's really important for your organizations is to really, one of the first things you should do is promote somebody to, or designate somebody to as a point of contact for COVID questions. There's going to be quite a bit of people who, or families, they're going to have a lot of questions. How is your organization going to handle COVID? And how are you going to communicate preparations and policy to families to reassure them that there are policies in place, that you're aware of symptoms? For instance, some questionnaires that might need to go out, I think will be something we'll talk about later. There should be a point of contact that can help all the staff and families so they're open lines of communication. I would say I want to talk a little bit about PPE. You know, as you start to consider engaging kids, having cloth face coverings is going to be an important part of this. When my daughter was ill, we all had surgical masks that were issued by the clinics. Surgical masks are a type of PPE. Cloth masks really aren't. They're not a medical grade. Though we do wear cloth face masks in hospitals, kind of like walking in between offices and stuff like that. But if we're engaging patients, we're wearing surgical masks. But these cloth face masks, I will just say, they actually do knock down large droplets, particularly if you are asymptomatic and you're potentially transmitting virus and you have no idea that you are. You would be doing so in a large droplet phenomena, as opposed to small droplets, meaning they stay in the air for minutes to hours. This is not the phenomenon here with COVID-19 for just general talking or breathing or even coughing or sneezing. It's not going to stay in the air for tremendously long periods of time. But these cloth-based masks are important. So one thing that I would consider is starting to develop some policy, starting to develop some literature that you can help teach and reinforce the use of cloth face coverings. Face coverings may be challenging for certain age groups. I think predominantly most pediatricians are saying, give the younger kids a chance to wear face cloths or these face coverings. You'll be surprised. It was pretty hard for me when my daughter was between the ages of 3 and 5 to keep these face coverings on, or the mask that she was issued. She did a decent job. And I think there are some caveats we've got to remember about who shouldn't have face cloths as well. So say face coverings should be worn by staff and students as feasible and are most essential in times when physical distancing is difficult. Individuals should be frequently reminded to not touch their face coverings and to wash their hands frequently when taking them on and off. I think that's very important. Let's see, a couple things about who you shouldn't put face cloths on. Children under the age of 2, or anyone who is having trouble breathing or is unconscious, anyone who is incapacitated or otherwise unable to remove cloth face coverings without assistance. We have some patients like that, or we have some kids that engage our care, particularly some of the ones who've had kind of neurologic tumors, who've had solid neurologic tumors and had surgery. So remember, face cloths shouldn't go on certain people, and that's one particular group I wanted to draw everyone's attention to. But they're really meant to protect other people in case the wearer is unknowingly infected, but does not have symptoms. That's really the best thing. And staff, when engaging kids, of course, should be wearing face cloths at this stage in the game, and likely for months ahead. All right, here's another slide, again, promoting activities that will prevent spread of the disease. So this is kind of a classic slide: hand hygiene and respiratory etiquette. When developing your policies and when considering your spaces where you may be engaging kids who have cancer or siblings or survivors, you need to have really good hand hygiene, respiratory etiquette postings as well as policy. So teach and reinforce hand washing with soap and water for at least 20 seconds. I would say ask the kids to do their ABCs when they're washing their hands. I personally like soap and water. Alcohol is a reasonable alternative. You just have to make sure if you're going to be buying alcohol solution, it's got to be or hand sanitizers, it's got to be 60% or greater. But you also have to be really careful about having hand sanitizers around that are unmonitored. 60% alcohol is actually a really high proof. It's 3 tablespoons of this stuff could actually cause a kid to become inebriated, even have alcohol toxicity. It's often forgotten. So, so I've seen a lot of offices have hundreds of bottles lying around. That's something to consider to not have in certain locations in your own spaces. I like soap and water better. You can have hand sanitizer, but have it in a monitored place. I would encourage staff and students to cover coughs and sneezes with a tissue. Obviously, if they're having symptoms, you want them to avoid coming into certain activities, but that's just a proper thing to make sure hand hygiene as well as respiratory etiquette is enforced. Any questions? I guess I'll get to questions at the end. The 4 items up here: avoid close contact with people who are sick. We're going to talk a little bit more about that. Avoid touching your eyes, nose, and mouth. Practice social distancing by putting space between yourself and others, and wash hands often. So again, a good thing to post. I did put some slides together about how schools have rolled out or classrooms have rolled out in different countries in the past month. And I've got countries from, South Korea, Germany, UK, you'll see in the next couple slides. There's a lot of variability. And this is one of the things I want everyone to be familiar with. There's a lot of pivoting, a lot of variability. People are trying things, they're trying to implement these policies that sometimes can have gray area or be difficult to implement exactly as it is written. You'll see variability. So take a look at South Korea. There's a lot of talk about cohorting. When you start programs up again, you really want to keep small groups. Small groups it's very helpful. For one, the smaller the group, the less potential transmission. But 2, if someone does develop disease after that program occurs, your contact tracing will occur, and it would be important to inform everyone that was there. And if you have a large group like the class on the left, that can be problematic because then you have a potential large exposure. None of these people, you can see the kids in this class some are masked, some are not. As opposed to Germany, you can see there's been implementation of social distancing, quite a bit of social distancing. That's what most schools are doing. They're making floor plans. I think that in your spaces, for particularly like ask when we have programs, we have enrichment programs or preschool, social distancing is going to be part of this first phase when we do bring kids back into programs. The next slide here are these partitions. It's important to think about the use of partitions. CDC endorses partitions in a classroom setting, but just think about how they may be used. Partitions do not replace mask wearing. They're not they just simply supplement. They're not a replacement. This is lunchtime for kids. Just, again, we'll talk about food services in schools. A lot of schools are not providing cafeteria-based food services right now. They're actually asking for food to be brought in. Some programs, that I would encourage, if there are going to be food services, or they're going to be actually meals that are going to be served or allowed time for during your programs, for the kids to bring their food in. That way you can deal with the allergy. The family is making the food, at least for the time being. And then you don't have to worry about an outbreak in the food preparer, the group of people who might prepare the food, because that has happened before. And then you potentially could have exposures that way. So that's something really to consider strongly. Also, if you're going to be having large groups of people, phase 3 of our governor's kind of phased-in plan will allow for 250 people to come, up to 250 people. So that's that's for certain groups. Again, we need to be cautious with our immunocompromised patients. I would definitely make sure a physician has vetted anyone who is immunocompromised to engage that type of scenario. I would not recommend that right now. Again, but we deal with a lot of kids who are essentially on the spectrum of immunocompromised. There's some kids who aren't immunocompromised at all, and they're survivors, and they've had what I call immune reconstitution, whereas others have are on treatment, and they wouldn't be appropriate for a group at all. So again, that's part of the gray area in the tough cases that we've got to deal with or consider. As you can see on the right side, this is a French school. Again, they've foregone masks and gone with social distancing, just to showcase some variability. Again, more social distancing in classrooms, something that you can do for your programs if and when we do escalate and start these programs up. It'll be important to do so with social distancing and floor plans. They've taped the floor to actually, so you don't have to think about how far people are apart. And on the right, you can see, again, showcasing the use of partitions, transparent partitions. All of these people should be wearing masks. And if you do use those, masks should be not foregone. There's a lot of chatter about communal spaces. Closing communal spaces has been, by and large, the policy. But the CDC is starting to pull back on that and saying if communal spaces are used by cohorts, a lot of hand hygiene and essentially disinfecting of playgrounds like this can be done as case counts in the community go down. So again, this is very important with our children. You've got to really get a look at each individual child. I would not feel comfortable without a doctor's permission to engage in this type of activity. So again, you're going to have to take each case by case scenario as case counts come down and as people reintegrate. I will say that adding physical barriers such as plastic flexible screens and bathrooms are considerations as well. There are physical, obviously when you go into stalls, those are good physical barriers, but a lot of disinfecting has to happen between people, between staff and if you have bathrooms for the kids in your locations, that you're gonna have to have a solid policy about how often that place is cleaned. Other things. So what should I do when my child gets sick? So again, I would make sure you have a policy about if you have a program and a child has symptoms, really all the children should be screened before they even come. But sometimes, as everybody knows, children will come and all of a sudden you'll notice while they're there that there actually is concerning symptoms at play. So I would say preparing essentially schools or programs may consider implementing several strategies. Advise the staff and families of sick students to just stay at home. That's the primary thing to do. But if you do have a kid who develops symptoms, you should make sure that the staff and families know that their children should not come to their program, that they should notify, for instance, the director of the program to make sure that not only is that kid staying at home, but at the same time, when can they re-engage? There's certain time frames. For instance, at least 14 days has to pass. But of course, a doctor would have to vet that before a child could come back, because symptoms could persist longer in the immunocompromised child. I would say it's really important to kind of work with some of the administrators and the nurses, and with ASK, for instance, we work hand in hand with our local hospital, and the nurses there and some of our child care specialists, we know these kids very well. So it's important to make sure that we are in proper communication so we don't have any kids coming to any program and potentially causing an outbreak scenario. So again, open lines of communication. But again, one of the worries is you got to make sure that you abide by HIPAA and medical release of information. So that is a touchy thing. That's why policy has to be written, and you need to consider discussing amongst your own group of nurses, physicians, and keep that just make sure you have essentially legal involved in all of this to make sure your policies are well kept. One thing about disinfection and disinfectants, I would say as you're cleaning your space, about 1 in 3 adults use chemicals or disinfectants unsafely while trying to protect against COVID-19. This has been a real phenomenon, not only in places outside the hospital, but even we've had some issues in the hospital as well. We've learned that some disinfectants aren't virucidal, essentially, against COVID-19. There's certain EPA designated disinfectants that you need to consider strongly to have on hand. And I'll show you the website. It's on a subsequent slide. If a child does get sick, or you find out that a child was sick, it's important to close off that area and do not use those areas until cleaning and disinfecting has occurred. Typically, we wait for 24 hours after cleaning is disinfected or cleaning has occurred and disinfection has happened. But if 24 hours is not feasible, waiting as long as possible is the next best approach. If you do have a child that develops illness and it turns out it is COVID-19, it's important to have open lines of communication with your health department. Usually if a child is sent out and they're diagnosed with COVID-19, that clinic will report that to the health department. It's a reportable disease, and a contact tracing might come and you might be notified that a child was infected. So that's something that's important to have open lines of communication with your health departments. Here is the EPA website. I would just, if you're going to be purchasing disinfectants, make sure it's on this list. It's called List N for disinfectants. So here's a COVID-19 epidemiology overview. Really quick. It's essentially with this whole lockdown that we have been under for many months now has been really, we hope to prevent some spread of the disease, but quite frankly, in a respiratory virus, we were really trying to spread the dissemination of the disease so that our healthcare system was not over capacity, as is happening in Sao Paulo and India right now, as we saw in New York for certain stretches of time. We want to prevent transmission, but we know that essentially the transmission is likely going to happen over many months. So again, flattening the curve. This is a good replication of that phenomena. This is just a graph that we follow. This is the Johns Hopkins site. Here is the Virginia Department of Health website. I just wanted to draw your attention to education settings, and I think we would be lumped under some of these, the services that we provide, particularly preschools or enrichment programs. They have not been a large part of the outbreaks. By and large, long-term care facilities have in congregate settings. But again, you've got to take this with a grain of salt. We've shut down schools for a long period of time. So know that some of the data that we're going to see has some bias to it. But be familiar where you can get this information. This is the Virginia Department of Health. And here's our downward trend in Virginia of new cases from the date of onset. So we're having a good downward trend. You don't see a lot about this. We're actually, compared to our neighboring states, doing a little bit better. South Carolina and North Carolina are seeing an upward trend. But you also have to realize we're having increasing testing as well. We're seeing a lot of new diagnoses with milder disease, but we've got to take that with a grain of salt. Usually the hospitalizations and the deaths, there is a delay by 7 to 14 days. I anticipate that we will have kind of a downward trend and a plateau until the vaccine is available. Talk a little bit about that later. Here are California numbers. California is just a representation of a state where it's going up, but again, it's in certain areas. It's not the whole state. It is a little bit clumsy statistically to just look at an entire state. The state has many different rural and urban environments. The urban environments where social distancing is very hard, it's going to be a respiratory virus will thrive a little bit better as opposed to in rural environments. California, this little almost heat map you see in the top right corner is a good example of that. And then I'll show you this graph just kind of shows you, or this histogram in the bottom left-hand corner. Deaths by age group in Virginia, we're not having any. We haven't had any deaths in these age groups, which is obviously it showcases that by and large it is an older group of demographic that carries the more severe diseases, more severe COVID-19 disease. And then here are hospitalizations and cases. There are certainly cases in the pediatric community from 0 to 9 years old. There's been 1,000 cases. And then from 10 to 19 years old, there's been over 3,000 cases. But by and large, hospitalizations in those demographics have been quite low. And the United Kingdom, just as I said before, has made an announcement that even immunocompromised kids have fared well with this when getting COVID-19. Granted, those are low numbers, and we want to try to prevent that. We don't want to necessarily contribute toward that, to that or test that out. But this should be a reassurance for everyone. Here, as opposed to influenza, where children occupy the majority of the disease and can have severe disease, as you can see in this graph, you can see the darker blue line is 0 to 4 years old, and then 5 to 18 years old is the orange graph, is the orange line graph, as you can see. This is this past year. So you can see there were 127 outbreaks in Virginia with flu. There were 3,000 deaths due to pneumonia. There were 6 pediatric deaths in Virginia in this past year. So it's a good cross comparator. So I've talked for about 30 minutes. Common questions parents will have regarding their immunocompromised children. I've gone through some of them kind of already. So I wanted to open some questions to the audience. I hope I fulfilled my objectives. And let's talk about some more detailed, programmatic things that you want to talk about.
We had a couple of questions come in. Thank you, Jody. One of them was, what are the best practices for keeping kids safe during snacks or meal times during programs? I know we saw one picture, but can you speak to that a little bit?
Sure. Let me pull up. Okay, now I can see the chat well. So that's a great question. So obviously you can't wear a mask during that time. So that's really when social distancing and partitions can be used. And I think that should be, I think that should have a good return on investment, essentially. I think though partitions can be bought very affordably, they can be cleaned very easily with disinfectants, and keeping the kids apart, definitely 6 feet apart, would be the best strategy. That's what the school systems are doing.
Are these going to be things that we have to follow until there's a vaccine, or does it not going to change depending on which phase we're in? That's what I'm wondering for some of these.
Yeah. So I honestly, the partitions aren't like an essential. The CDC kind of makes these are nice. The physical barriers actually have some sound science behind it. I think there's going to be regional transmission all the way up until the vaccine. The vaccine's probably going to become available as early as January 2021. I think that's a bit ambitious, but maybe May of 2021. We'll start seeing larger production. Anthony Fauci with the CDC says, with the NIAID, said that there'll be 100 million doses in January. So that would be great. And things will change. That's another big milestone, what happens afterwards. Our kids, particularly the ones on treatment, they'll get vaccinated, but they probably won't be immune. They might need booster vaccines. They might need to get their blood drawn again to see if they've developed what I call a neutralizing antibody. So that is something we've got to consider down the road too, that our kids will, by and large, the ones particularly on treatment or shortly the year after treatment, depending on the treatment regimen, can be immunocompromised for some period of time. So it's going to be for a while.
Okay. Debbie had a question. Would you suggest that kids can't wear masks or covering to carry a note from their physician, especially older kids, in the hopes of avoiding any confrontations with others?
We've got, we thought about that at our hospital. There are a lot of people who were, listen, I don't want to wear a mask. You can't make us wear a mask. It's a mandatory, wearing a mask is a mandatory thing to get services from our hospital. I think that unless there's some actual as I mentioned before, some people who wear a mask are potentially who can't actually physically remove it, who might have trouble breathing with it. Those are going to be very rare instances, but I would say masks should be mandatory for services in this phase in the game. I would make that a hard policy for staff too.
Thanks. And there's some comments that were posted on there if people want to share those or ask about this. I wanted to make sure you also talk about like accepting donations and both accepting them from people who, you know, want to give them to your organization and also sharing those out with patients and their families.
Yeah, so are you talking about just kind of they want to give toys and give various items that, yeah, so the CDC's made some recommendations about that. If they are given, like they're doing at VCU Children's Hospital, you go home. If you get markers, it does not go back into reuse at all. Those kids go home with it. Unless you have a toy or some type of item, if it can't be cleaned, like anything with fabric, anything with like, you know, any fibers or anything, those can't be cleaned at all. So they shouldn't be used. So I would dissuade people from making gifts like that. Now you can wipe down certain toys and put them into reuse after they've been disinfected. So you'll just have to make a judgment call about those. And I think I think certain ones are appropriate, certain other ones are not.
Okay, and I know you mentioned to ask having us let donations dwell when they come in for a certain number of days. Is that in place of wiping them down or in addition to?
Yeah, that's a really interesting thing. They brought the World Health Organization had a walk back a few days ago about and the CDC kind of addresses this in their guidance, that fomite spread is definitely, or the spread of the virus from shared touch surfaces, it does occur, but they actually have de-emphasized that as a major means of transmission. It's really a respiratory virus. The people who are getting this disease, you can typically track them back to someone who you're exposed to and that was unmasked with the disease, and you're within that radius of 6 feet for an extended period of time, like 15 minutes. So that's the real exposure. And they say, yes, fomite spreads can happen, but it's when we do our contact tracing, we're not seeing a lot of that. And that's why when I brought up kind of like your playgrounds, they're not seeing these random people walking by and touching a railing and there's no one around, and they're not seeing spread in that context. It still should be disinfected. You still have to be smart, but just it was a noble caution, I guess, but maybe overemphasized early on.
Hey, Bo, it's Jody. A question about sign and sign out processes for the programs. So I thought it might be helpful to recognize that we will need to potentially contact trace. So making sure you knew who was in the room at what times is important.
Yes. Yeah, you need to make an inventory of everybody who shows up for programs and make sure that you have good contact information for each in the event, you know, for all your events. Now that may be a significant list of people. If you think about it, if you do get down the road to a larger event, say of siblings and survivors, for instance, who are immune competent, you really need to know who those people, who was there. Because you hate to do it, but schools are going to have to do this. There's going to be COVID cases throughout the schools. It's just going to happen, and you have to be prepared for that moment. I also want to emphasize having the health department know who you are, just know who the contact is. It might just be having a contact list saying your health department number is this, and if you do have a contact tracing that needs to be done, do so with their help. I do it here in the hospital, and I'm an epidemiologist. So it's just important because they can give you resources too. Sometimes they give you PPE. You know, they can be a great resource, and they can teach you. They usually do their own contact tracings. So great question, Jody.
And I also thought about ahead of time thinking about where you will move a child to in your environment if they start displaying symptoms. I know when my kids were little, we went to Rainbow Station. They had a get well place. So kids got removed from the classroom very quickly if they had any sort of issue. Obviously not as serious as this, but it helped keep things down in the classroom. But thinking about what is your strategy if you've got a kid that gets sick during the day.
Yeah, I want to, it's a great point. I want to comment two things with that. So you want to make sure up front that you have the kids who are going to participate in your programs to do a questionnaire before they get there. I kind of made reference about symptoms. Usually it's fevers. Do you have any flu-like symptoms, which is kind of headache, muscle aches, headaches, or obviously a fever. And then exposures to somebody with COVID-19, that should be on the list too. And then those are some people have included because of kids typically have a GI component. Have you had any nausea, vomiting, or diarrhea as well? Having everybody who engages, if they have any of those symptoms, they should not participate. They should stay at home. So that's the upfront barrier. Say, hey, we'll get you next time if these are positive. And they should go see their doctor to make sure that they get tested. That will really protect you and your staff. So on the back end of that, your question about a space, schools have been encouraged to have a location, particularly one that is well ventilated, that maybe a window can be open where you can get good air exchanges. If you do have a kid who develops a cough, sneezing, fever, it would typically in the cancer population, you'll just get a random fever. Everybody who knows is taking care of anybody with pediatric, oncology, they just get a 102 temperature out of the blue. You have no way of predicting it. Have a place that you can secure someone until their parent can come pick them up, or they can be taken to, the healthcare provider. And in that space, you want to make sure you store disinfectants. You want to mask that child if it's appropriate, because the spread of the virus is by and large going to be respiratory. So mask that child if they're not already masked, and then make sure, as far as personal protective equipment, it wouldn't be unreasonable to have some gloves available for staff, and then they should be masked as well, as I said. So great question, Jody. Any other questions? Let's see.
So while you're reading those, do you think we should be doing, maybe you already covered this, active surveillance, like taking temperatures when kids first arrive, or is it more of a passive, just like asking questions?
Yeah,
to parents when they're being dropped off?
That's a great question. So I recommend in this population, if you can afford it, sometimes, I want to be understanding that some places can't afford a lot of these thermometers. I mean, the laser thermometer is a good thing to have. It can be off by upwards of 3 degrees. So it's what I've encouraged people to do is have the laser thermometer. If it's hot, I mean, I've had people go outside with totally normal temperatures, and I do the laser temperature on them, and it says 103 degrees. And I know they don't have 103 degree temperature. And I follow that up with an actual thermometer for these one-off cases, and then you get a real temperature. So I think that's reasonable to do. I think it's smart to do. So you would hate to say, 103 temperature just came in from a summer day, because it's a blunt instrument. Let's just say that it's not very sensitive. So active surveillance is preferred over passive if it's feasible. For a sign in and sign out process, I've heard of some groups using a password or pickup so that IDs and exchanging of paper and pens don't have to be utilized. I've seen that too. Basically what we do at the hospital and can be done here is if you do have a program like Britt or Amy or anyone who's working out there, you can actually be holding the clipboard and ask them as they come in, do you have any fevers, flu-like symptoms, nausea, vomiting? Have you had any exposure to COVID-19? And then check that off so they don't have to handle anything like that. I think that's a reasonable thing to do, and many hospitals do that, and many schools are going to do that too. Other people are so sophisticated, they have an electronic checklist that you can send out that some schools are doing, but that's a tall order, I think. Would you suggest that kids can't wear, would you suggest that kids who can't wear masks covering to carry a note from their physician? I think we touched on that. Any other questions?
Do you have any guidance about, well, like for us, I'm thinking about our delivery of the dream room furniture to a kid's home. I don't know, Sherry, if Make-A-Wish is doing any home visits as far as that. I know that used to be you'd go into their home to talk to the child about their wish. I don't know if you had any questions, or I kind of do about how to safely, or if there's any safe way to go to a patient or survivor's home?
So that's a great question. And we are now doing all of our interviews virtually. And in fact, have done 2 virtual volunteer trainings in the month of March. So we moved to that pretty rapidly. And for any wishes that we're granting with the family's approval and with masks and social distancing, if they need to be done in someone's home, we are doing them really outside. So anything like that's being done outside. And it's not happening a lot, but a couple of times a month, I would say. Debbie might want to add something else. She's with Make-A-Wish too. So I don't know if you have any other perspective there, Debbie.
Not much. Anybody who's come in contact with the kids, we're asking to be social distancing. We are having one kid picked up in a limo, the driver's staying in the front. They're actually power spraying something, cleaning the thing beforehand, and they'll really have no interaction with the child. And most families have been super receptive to that. We are having one contractor go in who's wearing everything, and only one person's going in, and the child won't be in the house during that. And then they're leaving shortly after they drop off and hang up the TV, them being gone.
Yeah, from an infection control standpoint, I think those are, if you're practicing social distancing and hand hygiene, we have had drivers, believe it or not, when we have a number of veterans who are driven to the VA to actually get their care. We have had a couple drivers later on find out that they had COVID. And so I think it's important for, if you've engaged a driving service, or if you or anything like that, where you're going to potentially have a patient with cancer, make sure they go through those surveillance questions too. Have some mechanism of screening them as well. And then as far as the actual, like hanging a TV, again, they have de-emphasized that being as a potential fomite. But if it's been kind of hung and or in a box for multiple days, the virus does not live on surfaces for months at a time. It's by and large dead. Granted, they've done studies about on which surfaces, anywhere from like a couple hours to 3 days. So that dwell time of 3 days is pretty reliable for most surfaces, and it's not going to be a cause of outbreak scenario of like that TV that you put in their home, or say you gave them a bed or something like that that's been in a box and you've unpackaged and constructed. It should be safe. Now, if you wanted to wipe it down, that's fine, but you have to be careful about disinfectants because some of them are quite caustic and can strip. Paint can dissolve, like Clorox can dissolve through many things, including metal. So consider that.
Helpful.
Anyone else have questions? Oh. No? Well, I think that about covers everything.
Yeah, so bottom line, I think surveillance questionnaires are important to start putting together. Make sure you think about active and passive surveillance at the front doors. You really should follow your local and regional guidance from, your health departments and your governors. Even the CDC really defers to them. So keep in touch with them. I think the engagement of doctors in this is going to be important. Make sure you have doctors' permission to do certain activities. Again, the ALL patient who's on active treatment shouldn't be coming to really any program where their kids around. I mean, we were told that right out of the gate. But as there are going to be breaks in treatment, always communicate with their oncologist or have the patient kind of assist in that. And I think, go ahead, sorry.
Actually, do you think siblings then, like we have a lot of survivors in programs who are really far off treatment, and we think we can probably serve them first. Siblings, I mean, do they go right in the same boat as patients because they live with them?
So that's a great point. I'm glad you brought this up. So I think again, case by case basis, survivors are going to be by and large immune reconstituted. By and large, there are going to be some exceptions to that. I think that survivors, they definitely everybody really who's a cancer patient should be coming with the blessing of their oncologist. Siblings, yeah, you've got to be careful. I would say you definitely want to, if you do engage siblings who are immune competent, you really want to have a smaller group. I think it's fine to start with siblings. Those siblings are going to go to school, so it's not like they're going to be at home completely quarantined. And I actually think, like for instance, our program with ASK would be able to really kind of put forth a great infection control kind of program amidst what they're instituting. So I think it's fine to do with all of these in place. And I would definitely start with survivors and siblings first. And then one of the things I was thinking about is, if you can, do these Zoom sessions with patients who are on active treatment. Sometimes, like when I see all you guys, I don't like seeing little kids with bald heads, but it might be something that's very enriching for them to see all their buddies who are on treatment. My daughter had 5 little buddies there. They're all bald, they're all little girls, and they saw each other on this, and it was actually really fun. So I think if that could be orchestrated, that's another type of program that could be really valuable.
Well, this has been so helpful. I think everyone's just thanking you now. But we'll send out your contact information, and if you have any other links you want to share, just let me know and I'll send those out to everybody.
Yeah, no problem. No problem. Thank you all. Thank you for what you're doing for our kids. They need help for sure. And you guys are saints in my book.
You're doing a great job too. Thank you. We'll talk to you soon. Bye, everyone. Thank you.